All right. So this next set of slides we're going to look at is the moral obligation. Obviously, you guys can look through this and look at some of the questions that are at the end, which is going, if we were in class, would be fodder for our discussion. But I want you to consider in the context of some of the writing that you guys are going to do for this week's assignment or that you have already done. One of the things that I want you guys to understand also is how we pay for healthcare as a result of everything that we have done and not done thus far based on the history of healthcare. What people's current situation is, really how our current system impacts people, our patients, and then tie it into this discussion of moral obligation. What is our obligation as people, as citizens, to carry healthcare? So before I go through the slides, I want to let you know there's a video under week 2. It's like a Healthcare Benefits 101. It's like a 2 or 3 minute long video. It's super nuts and bolts. But the thing that I want to highlight is that whether people have benefits on the exchange, or what we call the marketplace in Washington State, or whether people have employer-based benefits, a lot of healthcare plans work mostly the same. The expenditure that people bear is generally going to be higher for people who are on the marketplace versus employer-based benefits. And that when we are talking about the cost of healthcare to people, that generally most of these costs are not going to be passed on to Medicaid and Medicare patients. However, there's a different cost for them. And I'll get into that a little bit. So one of the things to understand is some terms. Basic terms are your premium, your deductible, your co-insurance, and your copay. This is one that I really like to write on the board, but since I don't have a board and I'm sitting in my car, I'll go through it as best I can. So your premium is basically like your membership to the healthcare network. If you don't pay a premium, you don't have access, period. People who get, quote unquote, get out of paying a premium are people who are eligible for Medicaid, which is for people who have financial need, may also qualify for some forms of disability, but generally is income-based, need-based. Think of it that way. Medicare is for people who are typically over 65 and or also on some form of disability. But people who are over 65 do not also have disability are also eligible for Medicare. They can delay that if they choose to delay their benefits and or their retirement to later as well. So some people will opt to delay their Medicare contracts until 67, 68 if they haven't fully retired at that point. Or if they're able to pay for what they call a COBRA, or sort of like a continuation of benefits plan through their prior employer. So what we're typically talking about is sort of like government-funded plans, Medicaid, Medicare, marketplace plans, or employer-based plans. Medicaid, Medicare typically do not have any premium that people pay out of their pocket, unlike employer-based benefits and marketplace benefits. Employer-based benefits, more often than not, the premium is paid by the employer. So for most of you who work in hospitals or will go on to work in hospitals or large clinics, your healthcare costs, not all your costs, your healthcare premium will be covered by your employer most often. I cover that premium for the docs and the other employees that work for me. So this membership fee is really, truly only borne by people who are on the exchange or the marketplace. Prior to ACA and what we affectionately call as Obamacare, it was borne by people who were self-employed and buying their insurance through insurers directly. For a bit of reference, an insurance premium for an incredibly healthy 30-year-old person is about $320 a month. For people who are roughly, early 40s, healthy, non-smokers, it's going to be in the ballpark of about $400 a month. And for people who are relatively healthy in their 50s and 60s, it can jump up to as high as about $600 or $700 a month as just a premium, just literally the membership fee to have access to the healthcare network. Not to use care, not necessarily to go in for a cold, not necessarily even to receive a vaccine. That is literally just to have access to the network. So for many of you, your premiums are covered. However, all the other costs of healthcare are still yours. So the other costs are the deductible, the copay, and the co-insurance. Copay is the thing that when you walk into the your healthcare provider's office, for those of you who may be in a position to collect these from patients, you might have a different side of it too. You might have a different perspective. But for the most part, most providers never see this interaction. This is the thing that the person pays at the desk really to be seen that day. So premium, copay is a completely different thing. Every time that they have a visit, they will have to pay a copay. Every time they walk in the door and get seen by you, your colleagues, another physician in the office, they'll pay that copay. There are several visits or types of visits that are exempt from copays, and those tend to be preventive care, meaning your one routine physical, your well male, well female visit per year, well child. So essentially your routine preventive care visits typically do not have copays. Your routine immunizations, so for instance, getting your Tdap or your flu immunization will typically not have a copay. Every other kind of visit, you have a cold, you have a runny nose, you have a UTI, you have back pain, all of those types of visits will have copays, and those are usually in the ballpark of $30 each. So those are additional fees that if you utilize your healthcare beyond the premium and the membership fee, you'll pay an additional fee. So it's kind of like the premium is your gym membership, and then every time you want to go in and work out and go to spin class, you have to pay another $5. It's kind of like that. So to some extent, people look at that and say, well, then people who utilize their care or have to utilize their care are penalized by having higher costs. It's one way to look at it. Other people say it incentivizes people to not go in for healthcare unnecessarily, potentially. So there's different discussions on whether or not copays are equitable in that way. Coinsurance and deductibles are two totally different things. So most plans will have something called a deductible, which is basically the number of dollars that needs to get spent on your behalf, primarily by you, in healthcare costs until your health insurance plan will pick up the tab. So think of it again, like I'll put it in terms of the gym membership thing. You go in, you pay $35 a month. I don't know what gym membership costs $35 a month anymore, but whatever. $35 a month to go in and go to the gym. You pay $5 a month or $5 every single time you go to spin class. And you have to keep paying the $5. The premium doesn't go towards your deductible, only the $5. You keep paying that $5 every single time until you hit your deductible. It's kind of like a coffee card points reward thing. So finally you're like, I hit my 10 points. I hit my 10 coffees. I hit my $500 deductible, or $5,000 deductible, which means, in the context of the spin class thing, you would have had to go to spin class 100 times to hit that deductible, twice a week, theoretically. If you have a $5,000 deductible, you would have had to go 1,000 times in that year to meet that deductible. Once you have incurred that many costs, boom, you're done spending. And then your insurance company will pick up all or more of the tab. That's called coinsurance. If you have a 10% coinsurance, once you meet your deductible, your insurance company will pick up 90% of anything else you spend, but you still have to pay 10%. If your insurance company has, will pick up, 80%, then you have to come up with 20. So where this becomes relevant is not very often in the context of office visits, but much more so in the context of ER visits. So an example would be this. I pay $400 a month for my plan, no matter what. If I never walk in the door to a single healthcare provider in all of a calendar year, it doesn't matter. I still have to pay that $4,800 every single year just to have healthcare, right? If I go in and use it, I have a $500 deductible. So now I have to go in, pay my copay because now I'm walking in the door, right? And I'm going to use healthcare, so I have to pay for that. I have to pay for them to talk to me. And then I have to incur $500 worth of costs. Now, if I go in for a cold, I could probably get 3 of those visits, maybe 4 of those visits before I hit my deductible. If I go in for massages twice weekly, I could hit my deductible in 4 weeks. If I go in for chiropractic twice weekly, I could hit that deductible in 4 weeks. If I go in for one ER visit, I'll hit that deductible in the first 5 minutes. But with a $500 deductible, the likelihood that you will hit that, you will incur that level of costs if you use your health care at all is pretty high, if you do anything beyond your preventive care visit. And then after that $500 deductible, so I walked into the ER, my ER bill ended up being $10,000. I paid $4,800 premium. That is notwithstanding. $500 to hit my deductible. And then my coinsurance will allow for the insurance company to pay 90% of my remaining bill. So now, minus the $500 from that $10,000 bill, so I got $9,500. The insurance company will cover 90% of that. So you got like 5, 4, so that'll cover about $8,500. So I have to come up with that remaining $1,000 for that 10%. So my coverage that I paid $4,800 for, and then $500 deductible for, still means that I have to come up with $1,000 for the one ER visit. I've now paid about $1,500, $4,800. We're talking about, over $6,000 to have healthcare and to go to the ER once in an entire year. I haven't even done anything else in my healthcare. So I illustrate all of this and go into detail about this. And if you know all these details, I apologize for the lecture. But I really want you to think about that when we get into this concept of moral obligation. So here we are. Because here's the different definitions of morals, ethics, laws, really just to ground this conversation in what we're talking about as moral and not necessarily a legal or an ethical conversation. Do we have a moral obligation as a country to provide health care? Well, when I illustrate that situation, that brings up a lot of feelings for a lot of people. Like, that's crap. Got to pay $6,000, $7,000, and that's a good plan. To have one ER visit and possibly one preventive visit a year that, didn't incur any cost. I mean, that doesn't seem fair, and is that equitable? Does that actually allow for the different dimensions of health and our socioeconomics and access and education in terms of people being able to properly utilize their health care? People who don't have like $500 to the name, let alone $7,000 to the name, how are they even going to pay for health care, let alone access health care? Simply having a health care plan is not access. So the things to think about, again, looking back at our history, what's the moral culture of this country? Think about the movers and shakers that have been responsible for policy change over the last 120, 150 years. What should our healthcare system be? If we have a moral obligation to provide healthcare, should it be to save me $7,000, or it should be to save my life? And if it costs me $7,000, yay, you're alive. And I think that that isn't to be flippant about it, but really, like, what is our cultural obligation? What is our moral obligation as a country and as a national culture? What are we supposed to do with this healthcare system? And I think that really, like, this is the stuff that is very difficult to discuss without people feeling highly emotional about it. Because what's the flip side? That if we don't provide healthcare to people who don't have the socioeconomic status, the flexibility, and or access to healthcare, are we essentially, conscripting them to death? Possibly. Are we telling them that, like, our healthcare system is not for them? Possibly. What amount of healthcare should also be included when we say, do we have a moral obligation to provide healthcare? Where does our moral obligation begin and end? Do we have a moral obligation to have healthcare? So now I've also described this scenario to you of, a person paying for a policy, how much one ER visit might cost, and so you can imagine why a lot of people are like, screw this, I'm not going to have healthcare. That's so expensive. Like, I'd rather take my chances. And if that ER bill was $10,000 and what I had to pay out of pocket was still about $6,500 to $7,000, what's the difference? All those years that I never used healthcare at all, I could have been saving $25,000, $30,000, $50,000. True. Now, the one event is near death where you don't necessarily, where your bill isn't just $10,000, it's hundreds and hundreds of thousands of dollars. Traumatic brain injury, stroke, where someone is hospitalized for weeks and months. Those bills we're talking in the millions. Most people will never have spent millions of dollars on premiums over the years. And another thing to think about is cancer. We don't know when these things are going to happen. We're going to be in a traumatic accident. We don't know when we're going to be diagnosed with cancer. And those treatments are much more long-term and chronic and incredibly expensive. And if we don't have health care for ourselves, who will pay for that? If I don't have health care and I'm diagnosed with cancer, who is going to pay for my treatment? On the flip side, if the government or some entity does not provide healthcare insurance for me, are they saying, I'm sorry you have cancer, but we're not going to help you. You're just going to have to die. Sorry. Or is it, I don't know, my fault for not thinking about, like, wow, I didn't anticipate this. Who could have? And now I have put everybody else in my community in a position of paying for my negligence. I'm not saying the cancer is, but the decision not to have health care or the inability to carry a health care plan. Someone has to pay for it. Who will bear the burden? So I think that these become incredibly difficult conversations to have when we ourselves are in these positions, and when we also consider the concept of pre-existing conditions. Who should be required to have health care? Well, let's see. What costs us a lot of money? Well, obstetrics costs 25% of our skyrocketing healthcare costs. All right, those people should probably have healthcare. Well, pediatrics, they go in their first year of life, every couple days, then every couple weeks, then every couple months. I mean, they often have 12 well visits and, any number of acute visits, but it's not uncommon for babies or children to be seen, 8 to 25 times in the first year of life. That can get quite expensive if someone does not have health care. Because each time they're going to be paying, $150 if they go to children's, maybe even $1,000. That they're going to incur a lot of costs. Older adults, people who have more chronic health conditions, statistically speaking, who tend to be on more medications, statistically speaking, their healthcare costs our system a lot of money. So they should be covered either by procuring it themselves or we provide it for them. And then young adults, basically we've named everybody else. We've named children, older adults, the, childbearing population in between. I mean, the only other population we haven't really looked at is young adults, but they also cost a lot of money too. Look at some of these stats in terms of how many young adults actually incur a good amount of healthcare costs. The one place where they don't tend to incur as many costs is within cancer diagnosis and chronic health concerns, but they definitely are a significant portion of ED visits related to trauma. So if you look at that last set, they're, nearly a quarter of ED visits. Some of it is inappropriate use, and some of it is just that, that population tends to be more risk-taking. Our car insurance companies know that. We stratify for risk, and risk doesn't really drop from the car insurance standpoint until people are 26 years old. Other considerations, of, who costs us money, and how much. And so when we think about who we have a moral obligation, if we want to think of it that way, to cover, and we look at our history and like, gosh, why have we done certain things? Why have we not done certain things? Why haven't we taken care of this group of people? Some of it is based on these numbers and how much they cost. Sometimes we cover them because they cost a whole lot of money, and to have them uncovered costs us more than covered, which we have found with older populations and very young pediatric populations. But there are certain populations of people that having uncovered is actually still cheaper than having them covered. And that's generally still been true up until very recently with young adults. The one place where this changed with, very notably with Affordable Care Act, was with the perinatal population. So pregnancy used to be a pre-existing condition. So at the time, ACA was just passed, but insurance plans had not shifted. So at the time that I actually was pregnant with my son, which, as things happen, the timing was a little different. He was technically a pre-existing condition, and they didn't cover any of the prenatal, intrapartum, or postnatal care. And in case you're wondering, a straightforward birth costs about $12,000 out of pocket. A straightforward birth, but with pain medication on board, cost about $18,000, and a surgical birth costs $25,000 plus, because then you're also looking at potential NICU and adult ICU admissions based on that. So at the point that perinatal care became very expensive, as our C-section rate and our surgical birth rate continues to increase, it made sense to include pregnancy and perinatal care as one of the covered conditions. We could no longer exclude them. So things to consider when we look at moral obligation and thinking about this particular discussion. What's our obligation to services, to which groups of people, to cost? How much cost is it fair to bear, and how much cost should other people bear? Finding that balance is really, is honestly what has been the trickiest part of this whole ACA healthcare reform. What's our obligation related to access? What do we have an obligation to provide? Is it just one preventive care visit a year? Is it ER visits? Is it all sick care? Is it maintenance care? These are the things that these questions are ultimately the thing that's fueling this current debate, has fueled the debate all of this time, but that really makes our next steps much more challenging, because it is very difficult to look at patient experience, cost, and improved population health and the triple aim all together without also looking at what is our obligation, what is our role, and which of these things are we obliged to prioritize? Are we obliged to prioritize cost because we have nearly quadrupled our costs in the last 60 years? Are we obliged to prioritize patient experience because so many people are unhappy with their health care? Are we obliged to prioritize population health because, that's, the wave of research right now, but also because it's the stuff that really seems to bring the utilization of services and medications and technology down? These are the things that, I want to plant seeds. I want you to think about. Maybe we'll have some more opportunity to rope that into our discussion when we actually see each other person next week. But if you have thoughts about this, I'm going to put a little discussion forum up on the week 2 modules, and feel free to post comments and further questions, because I'm happy to provide more explanations or further this discussion before we see each other again. So with that, I will end my car sermon and post these online.